So now for the truly exciting part of our day, we would like to welcome the first panel of local innovators to the stage. I'd like to introduce Melissa Johnsen. Melissa has more than 25 years of IT and business management experience in a variety of industry sectors and is bringing her talents big time to healthcare. She's currently the interim president and CEO of the Missouri Health Connection, and I'd like to invite Melissa and her hyper-distinguished co-panelists to the stage. Please welcome Melissa and the panel.
Is it on? Here. Well, I'd like to have what he's had, what he said. So I know that after the summit, I'm taking a trip to Geekistan, I think, and have my passport stamped. So before I introduce the panelists, I did want to just give a little background on what the Missouri Health Connection is. It is a state-identified entity for establishing the health information network for the state. And our network is to enable the sharing and exchange of data amongst healthcare organizations, enabling patients and the consumer to participate in the here we swap. Here we go. All right. The information network will enable doctors and hospital organizations working with their patients to deliver better care at the point of care in a secured fashion. We are a nonprofit. We have a board of directors that is a representative of public and private entities. We have physicians, we have consumer advocates that are represented on our board. And very excited about this panel because we share the same objectives and very interested to hear more about what you have to share with us today. So let me provide an intro to each of the panelists. Eric Armbrecht, and I hopefully am pronouncing it correctly, is Director of Consulting Practice at St. Louis University Center for Outcomes Research and Assistant Professor of Internal Medicine in the School of Medicine and an Assistant Professor of Health Management and Policy in the School of Public Health. Dr. Jeff Belden, here we go, is a family physician on the faculty at the University of Missouri-Columbia in the Department of Family and Community Medicine and is on the affiliated faculty at the Information Experience Lab. What did you say it was?
It's a usability lab.
Usability lab. And then Charlene Caburnay, okay, want to make sure, is a research assistant professor and has worked at the Health Communication Research Laboratory at the George Warren Brown School of Social Work at Washington University in St. Louis for more than a decade. And then Keith Mueller is the Gerhard Hartman Professor and head of the Department of Health Management and Policy in the College of Public Health at the University of Iowa. You're also the director of the Rural Policy Research Institute Center for Rural Health Policy Analysis. So thank you very much. And I think we now turn it over to... Yes, go ahead. The alphabetical order.
Alphabetical order.
Yeah,
Right, so I have the distinguished pleasure of following Mr. Park, who, wow, that was amazing. I think it's, I just want to shell out angel money to you, right? And rarely does anybody want to give that kind of money to the government. But so today we're going to talk about, we're asked to sort of give some comments on sort of what our relative centers and institutes and experiences are in this area of using health data. So I'm going to give you the perspective from sort of what I do and one of the organizations that I represent, which is the Center for Outcomes Research at St. Louis U. This is a group that does sort of, as its name implies, outcomes research, sort of the great intersection of public health, medicine, and economics is what we call outcomes research. It's very applied. We have no microscopes. It's a laboratory. We have no microscopes in our facility at all. We just have a big wall, big glass wall with a big secure lock on it that doesn't let anybody in because we have enormous amounts of both public use and proprietary data at our center. Our research is primarily focused in diabetes, cardiology, transplant, healthcare quality, which is a key issue, and I'll mention about that today, and then pharmacoepidemiology, or the side effects of drugs. So that's kind of a little advertisement for what SLUCOR is, and it's here in St. Louis. It's a relatively small but nimble group of professors and analysts, and we cut across multiple disciplines, so it's a very interdisciplinary group. So I guess I'll give you some examples of health data use from the perspective of the Center for Outcomes Research and what we do. We're not a web app developer or we don't build APIs, we use them, but we don't build them. We have some spin-off work that we do in application development. For the most part, our shop does not do that. We really are involved in four, we think, practical uses of data: quality improvement. Not going to talk a whole lot about that today, but quality improvement from our perspective is how do you drive improvements from the clinical setting in real time, right? So how do you, these are a lot of health system-based or provider-based types of work that we do. Academic outcomes research, we'll talk a little bit about that. The informed planning to address community needs and focusing interventions to maximize benefits. So, I mean, we make use of public use data sets. This is a study that we did that looks at hospitalization rates for heart failure and how they have, looking at health disparity issues, which is a key priority area for our university in terms of reducing health disparities both in St. Louis and in Missouri and across the country. But this looks at, for example, of how health disparities for heart failure have actually, this is from 1996 to 1998, how they've actually gotten worse over time, and for this is heart failure and for acute myocardial infarction, it's really that health disparity over that same period of time has practically been eliminated for AMI. We use hospital and administrative claims data to do a number of things, sort of more of a methods perspective. So this is the type of data that our center uses to do things like study implantable cardiac device procedures and what their effect is in older Americans. We use patient registries and plus economic data, right? So looking at studies that have to do with, say, renal function, but really bringing together patient registry data and economic data. We look at health plan claims data. So one of our favorite types of work to do, which is medical and pharmacy data integrated together. This is a study that was based off of basically a major health plan in the United States. Is a nationally representative study looking at the underutilization of beta blockers in patients undergoing implantable cardiac defibrillators. There's a couple studies that came from this device sort of space. But one of the other areas that we think is important is informing planning to address community needs. We struck a great partnership with the Missouri Hospital Association to build to really get hospitals to look at what preventable hospitalizations are. And so our center had sort of issued this report in collaboration with the Missouri Hospital Association. All this is available on the Hospital Association's website if you would like to take a look at it. But we specifically were looking at preventable hospitalizations, what's happened over time there. So it's a specific class of hospitalizations, a specific method to analyze it. It's a longer talk than you care to hear about today. But we looked at, say, how preventable hospitalizations varied by region in Missouri, for example. And you'll just sort of see the big center line sort of gives you an idea of what happened in Missouri. So keep in mind that this is how the rate of hospitalizations have declined for preventable hospitalizations over this period of time. It's important to realize, though, discharges for hospitalizations over the same period of time were increasing by about 3%. So preventable hospitalizations have actually shrunk as a percentage of the overall book of business for hospitals in Missouri. We took an interesting analysis of this and looked at, say, for example, try to give you an idea of the different types of work we do. We looked at preventable hospitalizations that were attributable to chronic conditions versus those that were attributable to, say, acute conditions, and then mapped them together to give an idea for people, for hospitals, or for communities that were planning how they're going to invest their public health or their community health dollars. All of this sort of ties to a bigger initiative that hospitals face, which is demonstrating their community benefit, and it sort of ties into a specific agenda there. But this, in terms of trying to make data doable, every county, we did a report, a 2-page report, visual report that summarized preventable hospitalizations in every county in Missouri. And so we did this for 115, plus some counties outside of Missouri that are served by Missouri hospitals, like the east side in Illinois and the counties in west of Kansas City. This should give you an idea of sort of how we're trying to visualize this data. We think, for example, that the communication of this type of data is a really important part. We can do the technical analysis, but it really comes down to how you're going to communicate this. And this is why some of the web apps and the tools that Todd talked about are so vitally important, because you've got to make this information consumable and usable. That's really one of the most difficult parts of the type of work that we do. And then we also did a report that focused on health indicators specifically. So 1-page reports for every county or for hospitals in that county to really get an idea of what their priorities should be in their specific communities to help them invest their dollars. There's a major initiative going on right now that's being led by the Regional Health Commission looking at health indicators over a 10-year period of time from 2000 to 2010, sort of coincides with the release of the 2010 census data. This is being led by, like I said, by the commission, but Dr. Dolores Gunn and Ms. Pam Walker are chairing a work group, and we have the privilege to be affiliated with that a little bit. I want to talk a little bit real quick on focusing interventions to maximize benefit. I was affiliated with a project. This is a map, right? Dark red is bad. Less red is not as bad. Everything's not great. So this is inpatient hospitalization rates for children with a diagnosis of asthma. So one of the things about in 2003, the state of Missouri and its asthma program said, we need to focus where the need is. And one of the points here is that one of the great ways that data can be used is to identify where to focus interventions to maximize the benefit of public dollars or private dollars that are being spent. So this particular project, we said, well, look, this county down here is Belden County, Missouri, in the Boot Heel, had the highest hospitalization rates in the state for asthma for children. So we embarked on an initiative to develop interventions, and kudos to the Kennett Public Schools and Peggy Gaddy from the state of Missouri, and a woman by the name of Deb Cook, who's a school nurse down there. And this is what happened over that period of time. With a focused intervention that started in 2002, 2003, these hospitalization rates for children younger than the age of 15 have fallen from 161 per 10,000 down to 54. Still not at the state average, but I just looked up the data for 2009, and it's fallen again to 34.4. The point is that these public health indicators that we struggle with not always thinking that are movable, they actually are movable. And sometimes it depends on when we need to focus in areas where we can invest resources and get a return to maximize that benefit. A few quick comments here on challenges that we face, because I think this might be useful for the discussion period, and then I'll sit down. Data acquisition costs are expensive. It's the type of work that our center does. We spend lots of money buying data from commercial providers of data sources. When I tell you that we spend hundreds of thousands of dollars for data sets that frankly should be probably free, so it's a joy to know what the federal government is doing in this area to release, for example, Medicare data, right? This is public data. That is that the taxpayers have purchased the services. But historically, that data has been practically impossible to get your hands on. So we're very excited because initiatives like the Health Data Initiative should reduce data acquisition costs and accelerate academic research as well as other types of things. There are privacy concerns, and we'll talk about those a bit later, but maintaining those is something that's very doable, at least in an academic environment. Getting data down to the community level, a lot of the publicly available data set will give us state-level data, very, very rich data on estimates of, say, diabetes prevalence at the state level. But it's very difficult to get that information at the community level, which is where we really care about it. Right, so this is the trick. This is my challenge to Mr. Park and other folks, is like, how do we get this to the granular level that we care about? Because frankly, we in St. Louis don't give too much about, I was going to use an explicative there. So then I heard my grandmother echoing from right here. She's deceased, that's why I can hear her. So she said, don't say it. We don't care what's going on in Kansas City too much, right? So we want to keep things local, and we need the ability to have community-level data. Measuring quality of care is very challenging. Pricing information is huge. Right? So this is very difficult to get your hands on. And in a consumer-driven, this is my challenge, right? So in a consumer-driven economy with healthcare, you cannot make rational choices as a consumer without information regarding price. So we can get info. Thank you. I mean, a lot of people don't care about this the way that I do. So we can't help consumers make information on quality alone. Price is a very relevant thing. I'm going to show you some information here about why quality is sometimes very difficult to parse apart. Okay, so price is very important. There are unintended consequences, careful communication. Let me talk about this, for example. So I don't mean to pick. This is I brought this up, and it's the only kind of comment. I don't want to pick on Barnes by any means. But this is an issue that comes out on measuring quality and careful communication about publicly available data on quality. So I'm going to raise a point here that says there were headlines that came out when this particular news was released on Hospital Compare that Barnes had terrible readmission rates for heart failure. Okay, terrible. I mean, there were a couple stories that ran. They were not good. If Mr. Lipstein's in the office, I mean, there were nice letters that sort of explain some of these types of things. So I want to raise this point that looks at, say, that Barnes Hospital had a rate that was 28.4% of their heart failure patients and it was higher than the national average. And they were cited as being one of the worst in the country, worst in the state. Now, by the way, if that number was 1 percentage point less, it would have been considered no different than the US average. That 1 percentage point on this particular sample equates to 14 people over 3 years, which is 5 people a year. I've rounded up. The point is that sometimes we have to be careful about how we communicate these results and understand the magnitude of the impact, rather than just the statistical anomaly or the statistical fact that this particular health system was an outlier in this particular year or this particular analysis. I bring that up because it's a really important point as we start to make available this type of data, how we also provide some cautionary use about how it's used. And maybe that's the academic in me sort of speaking, but I just sort of bring this up, and I pulled these 3 hospitals because they basically serve the city of St. Louis population. Last point has to do with unintended consequences sometimes. So this is total kidney transplants from 1998 to 2009, basically. You'll notice, for example, something happened here. This is from colleagues of mine at the Center for Academic Research. Dr. Mark Schnitzler and Chris Valentine have been tracking these issues over time. Something happened in 2006, 2007. Had to do with some public accounting or public reporting of data and a shift in transplant centers, sort of how they manage their risk by selecting different patients who got transplants. Is sort of the hypothesis of it. So one of the unintended consequences, sometimes there are unintended consequences of data, right? Which is that providers then react to the data that is now going to be public and manage that in a way that you may not want, right? So we have not seen necessarily an uptick, a steady climb in kidney transplants like we would like to see. Right? Kidney transplants are very therapeutic, beneficial, saves actually Medicare lots of money. But maybe there's a sort of an unintended consequences sometimes. This is a nuanced sort of point, but I guess I want to raise this as sort of a, understand that there's one of the challenges of public access to data and is that there might be some unintended consequences. Careful communication, and then I would ask the last point sort of is this timeliness of the data, right? So if you're using a web app that's based off public use data that comes from the federal government, that's based off of patient satisfaction scores at the various hospitals, and you're saying, oh, well, which one should I go to? That data is 2 years old, right? So that it may be 18 months if you're lucky. So the issue here has to do with that hospital is not the same hospital as it was 2 years ago. Any hospital manager in the room will tell you that they've made changes based on that. So you just need to proceed with caution in terms of timeliness of data. So the challenge is that what we want is actually not just data. We want data that's timely, especially if we're trying to influence consumer decisions about it or produce academic research. Okay, that's it. I will sit down and shut up.
So, Jeff.
Thank you.
Is there a button I push, or just hit the space bar? Hi, oh yeah, that's for when I go to medical talks, and I have to worry about it. So I'm from the University of Missouri, and we have a collaboration with our vendor, EHR vendor, which is Cerner, another Missouri corporation in Kansas City, to a project that was designed to help improve the EHR for the management of chronic disease in a medical home setting. Because we were finding it was taking us too long to use the tools that we had. So at the same time, one of our research teams had an ARC grant, AHRQ grant, to evaluate the effects of implementing new technology. So they looked at when we turned on these new features in the software, how did that go, and could we demonstrate improvement in quality measures? And also we are interested in how this is going to have an impact on our health system, the academic health system and the larger health system it's a part of. Can we start looking at patient outcomes, and can we drive any of that? So our project involved 3 tools. One is this dashboard that I'm going to show you first, and I'll talk about the details in a minute. But a dashboard is a visualization technique for data where you bring the most important data for the task at hand right in front of the user, so you don't have to navigate around to find everything. So on the left we have the problem list and the home meds and the allergies. And in this upper right section a few vital signs and a few key lab, not every lab, and a few things that aren't lab, like the eye exam and the foot exam at the bottom of that first section there. Things that are quality measures that the physician needs to pay attention to. And at the bottom, we kind of have a quality dashboard where on the left you have these idiot lights. The red light is, hey, you're not on target there. You need to do something about getting the LDL cholesterol down. And then on the right, the little bar graphs are cohort performance. So for all my personal diabetics that I'm taking care of as a physician, how am I doing? So the problem was that it took too long to look through the data for the office visit for chronic disease as a family physician. And so I need to give you a brief overview because only about a handful of us are physicians in the room. So what it's like in a doctor's 9-hour day, and they're not always as short as 9 hours, is a face-to-face time with people, the patients, is only about 55% of the time. And another 25% is getting ready to go into the room or finishing up afterwards. And then another 20% is handling all the other stuff that comes in. So 5 minutes difference in a 15-minute office visit is huge. So we're trying to find ways to reduce the amount of time that we're spending doing our job. And chronic disease visits take more time than regular visits. And so in a chronic disease appointment, it's common for me to have more than those 5 diseases up there, but those are just common ones: diabetes, high blood pressure, hyperlipidemia, depression, and insomnia. And that might be only the ones that I focus on today. So in the first 6 minutes, we just kind of get ready to go into the room and look up all the stuff, and then I try to train new physicians, just listen to the patient's story for the first 2 minutes. Don't ask questions, don't interrupt. That's a hard thing for us to do, but it can be done. So listen for 2 minutes. Then we have to gather the rest of the story. Then we examine the patient. We're already over time budget. We need to have a conversation with the patient to negotiate a plan. And then we got to do some prescribing. And then we have to manage the formulary changes because your Lipitor is no longer covered this year. There are some cheaper things. And then I have to finish my documentation, which a lot of doctors now take home at the end of the day. Sorry you had to wait. So my goal, my mission, and my professional mission currently is to relieve physician suffering by improving the usability of the software they use. So I'm a usability evangelist. So our goal was to design this project that could do 3 things. 1, build a dashboard. 2 is build some clinical decision support algorithms. 3 is develop these quality reporting at the point of care tools, and I describe them as idiot lights. So on the dashboard view, I walked you through that a minute ago, but as a physician, and if I'm seeing you for your diabetes and high blood pressure, I got to see, do the abnormal things stand out? So if you look in the right-hand clump of things, do I have an arrow? The creatinine, there's the things that are orange are high, and they're bold, and you have to it can't just be a color because not everybody, and some people are colorblind, so the information design needs to factor in all the visual perception science that we know, and I can tell you a couple books for that to help do it right. And on the far right hand, we've got little graphical trends, little spark line graphs where I can see 3 to 5 years of data without actually having to look at the graph. And these here don't show the normal range, but the final version does. This is the support algorithm. So the algorithms we aimed at were for primary care doctors. Keep it fairly simple, the first few steps. They're aimed at learners, medical students, and residents too. So we didn't have to cover the entire spectrum of how you might manage diabetes, just the first 3 to 4 different steps. And we also focused on economy, so the little dollar signs there give you the relative cost of the drugs. And then finally the dashboard I talked about earlier, and that's the red idiot lights mean you're off target, the gray means you didn't even measure that yet, and white means you're doing well. So we thought that this might save doctors some time, and so we did a quick and dirty test and proved it did. So then we needed to prove it more rigorously. So we did a study, usability study, and what used to take 60 clicks and 6 minutes to go find the 8 quality measures and get ready to go in the room, we were able to reduce to 3 clicks and 1 or 2 minutes. So that's a huge time saving for each visit, which translates into I can sit and listen to more of your story. You and I can have more of a collaboration in the decision making in your care, and it's not just I'm going to leave the room and the nurse will come in and tell you what we're going to do, or go fill this prescription. So, and the physicians loved it. User satisfaction was huge. And we could show doctors a 90-second video before they used this software, and that was enough for them to know how to use this new feature. So it was easy to learn. There were some unexpected uses, though. So, you know, we're doing electronic things, but doctors like this page printed out. So if you print it out, it's actually like having a second monitor in front of you. Now you've got your laptop you can navigate through, plus you've got that screen always open. So we can use it to make notes about which diagnoses we bill for. We circle key things we want to talk about with the patient. And on the far right-hand part, I can start making notes of the things I want to do by the end of the visit. And then we can give a copy to the patient and take home. Again, it fosters the conversation where I can focus on, here's how you're doing, here's an area to focus on improvement, and here's your updated medication list. And then patients, I found, were getting innovative, and they would just cut off the left-hand third and fold it up and stick it in their wallet, which is more portable than their current, and it's more readable than their previous versions. Compared to, right now, the standard visit summary that prints out from our EHR vendor, and this is fairly typical, looks kind of like that. Actually, most of that first page is an advertisement for the web portal. Don't you want to sign up for the web portal? And then the later part is their medicine list. Let's see if the animation works. So yeah, so there's the advertisement for the web portal. Another nice feature of this is that for physicians to get a carrot for doing quality care, the vendor now can automatically report my quality measures to Medicare so that I don't have to do anything. I just have to sign a piece of paper and say, it's okay for you to turn in my results. And then I just get a check if I've done well, which we do. And this new dashboard tool is very commercially successful for the vendor, helped them sell a lot of new products around the world. And also it's extensible, so they can take that same software tool and use it to make a variety of different dashboards. They can monitor critical care units on ventilator patients, and they can monitor people that look like they might be going into shock otherwise. So, oh yeah, and the vendor was also happy. So we also learned that what we were interested in was to find out if we put this quality information in front of physicians as they go and give them feedback on their quality measures, can we have an impact? And the answer is, if all you do is give them information, it doesn't really change the behavior and improve quality scores. You're going to have to do more than information. You're going to have to build in other process changes and workflow changes to get that done.
Good morning. I'm here to show you a new tool called localhealthdata.org that emerged from over 8 years of work on a research project funded by the National Cancer Institute and called Ozioma. Ozioma is a Nigerian word meaning good news. And our Ozioma project team has been working with minority media, specifically African American newspapers, in order to enrich the information environment in minority communities. And we tried to do this by making health stories locally relevant. We created the Ozioma News Service that produced cancer stories like this one and sent them to Black newspapers across the country. We found and inserted local health and cancer data specific for each community, and we searched all sorts of databases and data sets for these data for each story. And after the first 5 years of doing this work, we found that our Ozioma News Service increase the amount and local relevance of cancer coverage for newspapers receiving our stories, their communities, and their readers. We then wondered if we could streamline this process to identify local health data and use these data to create locally specific health stories. With stimulus funding from the National Cancer Institute, we developed an automated tool to increase the community relevance of cancer news. And as Todd had said earlier, with all of the health data that are increasingly becoming available, We wanted to build a way for these data to have more community-wide impact and improve health. And with localhealthdata.org, users can search for cancer statistics from trusted sites in one place, view the data in plain language, and create a unique news story or press release. We built this tool for user groups like journalists, media and communications specialists, and policymakers, or those who inform them, though many others could also benefit from this tool, including the audiences these groups serve, like the general public. So I'm going to jump right in and show you around the application. So with localhealthdata.org, you can search for cancer and health data from trusted sources. First, I'll select breast cancer as the health topic and say I'm interested in getting breast cancer incidence data. I'll select that here. I then select my location. I can also filter the data by race, age, and year. Right here, we provide a description and the source of the data. And here are the data for St. Louis City, which I moved to my virtual notepad. You might notice the data are in sentence format using plain language. So for example, we don't use the term incidence rate. We say the number of new cases, which makes it easier for the general public. Ozioma's image library allows you to view more than 500 photographs with filters to narrow your search. Here we've filtered the images to narrow the choices to African American women ages 50 and older doing physical activity. And here in the charts section, you can generate a chart using data like cancer mortality rates, in this particular example, then add it to your story. So here are the Missouri data. I can also compare these data to another state like Illinois. Now the Drafts tab allows you to create a story and add these local data into it. I add the data sentences from my notepad here, but if I want to send it to multiple locations, even to thousands of people, the specific data appear as variables. Then I can send an email to my story to recipients in many different communities. They would receive this link to access this site, choose their location, and the system creates a document with data for their community. Maybe you want some additional information to help round out your story. The Ideas tab can help generate some of these ideas. For example, we have links to RSS feeds and also have a calendar of health commemorations. Localhealthdata.org contains data from over 70 sources, over 300 data sets, and over 500 photographs. These 71 sources include agencies and organizations such as CDC, NCI, and the Census. And these 300 data sets include those from SEER, BRFIS, and county health rankings. We launched the application on June 9th, and 8.5 months later, with limited marketing and promotion efforts, we've had over 6,000 visits to the site from 37 different countries and 48 states, and almost 3,000 of these were unique visits. Of the 318 data sets in local health data, 82% have been accessed, a total of 772 times. And from these visits, over 12,000 individual data points have been clicked. And over 4,500 users have gone all the way through to the Charts tab and created their own chart within the application. So we're pleased that people have been using local health data and using the different features in it. And overall, we're pleased with the use the application has received, especially since it's designed for very particular use and target audience. But we still want more users. We've had the opportunity to talk with some folks who have used local health data and to see how they've used it in their work. Health journalists, advocates, and educators have used it to uncover trends and identify health disparities. Grant writers have used it to provide justification for increased funding in a particular locale. And interestingly enough, our initial list of potential users did not include those from academia, but we found that this tool has been useful for them too. At Washington University, we've had professors use them in their class lectures to highlight health disparities, and students have used it to find data to support their class papers. And others have used it to find culturally appropriate photos for their own health education materials. We've learned some lessons along the way, and the first is that usability testing is super important, and it's helped us out a lot. We conducted testing both before and after development with potential user groups. And second, even if the data aren't ours, we have to prove that we are a credible source. Third, it's all about location. The more local, the better, and that's what Eric had said earlier. And last, the more data, the better. People are always looking for more data, and data that are more relevant for them. And we welcome all ideas for collaborating to expand our offerings of local data sets. And in conclusion, we've built this platform for journalists and others to help build a locally relevant story with local data and graphics from this tool. And imagine if other types of data could also be added to local health data. What if experts in any given health field, cancer survivors or caregivers, volunteer to serve as a source for a journalist writing a story? Not only could local health data house the health data, but it could provide the link to a specific person who could be interviewed. Truly one-stop shopping. There's so much data and information out there, and giving it more community-level impact would be so powerful. Thank you.
Thank you. I don't have slides, so you can take your eyes off the screen for a moment. I'm going to talk about the context, challenges, and uses for health data, health information when you're doing rural health services research or trying to influence the development of public policy from a rural perspective. Let me lay out the context first, and this is one visualization I'll have to ask you to kind of visualize in your minds. I don't have it on the screen. And that is, we want to have ways that we can take something that is information, oftentimes collected for administrative purposes, like billing, charging, that generates a claims database, or encounters that help a system think about how many people their providers are seeing. So for administrative purposes, it's collected on the one hand. Then we want to convert that into data that's useful in a research activity. And it's not necessarily a one-to-one conversion. There are elements in that data that we need for more precision in research activity than may be needed for filing a claim, and vice versa. Then the final piece of that visualization is taking the data that we have and the research results that we generate and doing what the presentations on this panel have been doing, translating that back into information that's useful in either a policy or practice environment. So that's the general context. It's what's the quality on administrative data, how do you translate that into administrative information, translate that into data that's useful in research, use it, and then translate it into information that's useful back into policy and into practice. In rural health services research, we have particular challenges with all three of those elements. The first of those challenges is what we call the tyranny of small numbers. So if I'm trying to investigate a phenomenon in rural America, let's say the rural upper Midwest, and I want to be able to differentiate population based on age, race, and gender, I'm going to have a lot of difficulty in rural upper Midwest. Being able to do that at a level of refinement, anything below statewide data if I'm looking at non-metropolitan areas. So the tyranny of small numbers is challenge number one. Challenge number two is having the appropriate units of geographic analysis when you're talking about health services research. A lot of our data are driven or are available to us by county boundaries, and yet when you're talking about the delivery of healthcare services, you're really talking about a healthcare service area which is not the same as the county boundaries. The third challenge that's already been mentioned is the cost of acquiring the data. And that can affect the availability, it can affect the quality of data. How do we deal with those challenges? The challenge of small numbers, we really have to be able to access highly secure data, because we've got to be able to drill down low enough geographically to make statements about rural America. So for example, if you're using a national survey database, generated, say, for example, by the Agency for Healthcare Research and Quality that generates the Medicare Expenditure Panel Survey. If you want to use that data, MEPS, and drill down to a level of geography finer than all of non-metropolitan, The way we're set up currently is you have to go to the MEPS data center and go into a locked, secured environment because those data are highly sensitive and protected for individual identity. So it's a challenge. I just laid out one of the ways that we try to deal with that, but that's one way to deal with the small numbers. A second is aggregation. And how can you aggregate across time or across units of geography? And the third is statistically, and I'm a political scientist, not a statistician, so don't ask me for detailed description. It's called borrowing statistical power. So if I have two areas that are very, very similar, and in one area I have enough numbers to generalize, and in the other I don't, I borrow from the area where I have enough numbers because the characteristics are so similar. How do we deal with the geographic unit issue? We need data at the smallest unit possible, and that for most of us is either zip code level data or census tract level data. If we can get that, then we can build back up, but you can't come down from county level to either of those two. And sometimes we just have to flat out estimate at a local level. The cost. There's a cost of data collection. So if just on the start out with the administrative data set side, if you think that all claims data are alike, they're not, because they'll get various levels of investment from those who are filing the claims depending on the linkage between that claim and their actual final payment. So if it's a cost report kind of data environment, if the cost report doesn't generate the final payment, the cost report's not entirely reliable as a data estimate. We've done a study out of our research center comparing cost report data, this is in the Medicare system, to final audited reports, and there are some important differences between the two. Cost tied to, and it was mentioned earlier, what it takes us to acquire the data. If we're seeking claims data sources, for example, from the Medicare program, for some of our studies, we're spending between $10,000 and $20,000 per study just to acquire the CMS data because of the system we currently have in place to acquire that data. So those are some of our challenges. There are ways of dealing with that. On the cost of data, we do everything we can to be very specific about what we need so we lower the burden to provide the data, which lowers the cost. How do we end up using the data? Our center uses the Medicare Current Enrollment Database, which you can get off of CMS, to publish on a quarterly basis reports of changes in Medicare enrollment by county across the United States. I'd point out tyranny of small numbers. We can't report counties where the total enrollment is less than 10. So our national figure doesn't look exactly like the actual national enrollment because some counties get thrown out. We look at quality reporting data like the Medicare Compare databases to look at quality across urban and rural facilities. We use national survey data a lot, even when we have to go to the data center in order to be able to do that. We're beginning at our center to use the claims databases, which is my discovery of how much that costs this year. We're looking at provider location data. The National Provider Identifier is really great, and it does give you information about where the providers are. And most recently, we're not doing this, but colleagues in the field are looking at the CMS ACO cost savings data that have been released. Let me conclude with a specific policy arena example of bringing the information to data to back to information for policy use. Currently, there's a raging debate about the value of critical access hospitals. These are small rural hospitals, fewer than 25 inpatient beds. And they've been under a lot of scrutiny because they're paid on a cost-based basis. Well, for those hospitals and for the delivery of primary care in those communities with critical access hospitals, we need to be able to answer three questions. What difference does it make in the health of the population in the community? We need the quality indicators that are available in Medicare Compare so we can look at health outcomes. And we need to bring that down to the critical access hospital even though they don't perform all of the same services and even though they don't have the same number of patients. And my colleagues at the Upper Midwest Center in Minnesota are doing that, as well as researchers working with the National Rural Health Association. That's health. What are the costs? When looking at costs associated with one type of provider, you really need to look at all of the costs for episodes of care in that community. So going beyond the simple cost report data for an inpatient admission to a critical access hospital to include all of the data that are incorporated into the ACO savings database. That's been done, and it's a very powerful indicator that the total cost is actually less in most of those places, even if the inpatient admission is higher than an inpatient admission in a PPS hospital because of the nature of the delivery system. Finally, third, what is the effect on the local economy? We use a database that's generated through an implant model and an organization called Rural Health Works to look at how many jobs are related to the activity of primary care in a community critical access hospital and its providers, and what the economic impact is in terms of revenue to that community. So that's context, challenges, and in the end, we can make a difference using those data to help influence an important policy question.
Well, I think we might have just a little bit of time for some questions for our panelists. We have microphones on either side of the auditorium, and welcome folks to make their way to the microphones to ask questions. I'll kind of get it started here. I'm interested in understanding how you engaged the physician, the provider, in the work that you did and the development of the tools and the research that you embarked on. How was their voice brought in and informed the work that you did, and how did it change possibly the direction you went?
So this is our project, right?
That,
yeah. So early on the project, we involved about a handful of family physicians, most of whom were doing geriatric care, chronic disease care. Had conversations with the software people saying, here's what we need, and they'd said, well, that's going to be hard to do. And then after a few months, they said, oh, wait, we found this team that's got this, web page skin, maybe that'll help us. And so then we had that conversation. And then we did some whiteboard sessions and said, here's what we think it looks like. And then we had a couple physicians that were basically on the iterative group that one of our local software engineers started writing the code, and then it was back and forth all the way along to say, get rid of those words. We don't need to have those 12 words about the drug, just the name of the drug and one a day. So that was a key part of it.
okay. Do we have any questions from the audience at all? Do we have one? Here we go. All right.
Hi, I'd be interested in what you know about what's going on with a medical wireless home, especially as it relates to the December summit in Washington, D.C., and some of the activities, that Qualcomm is doing. So in other words, you have people in rural and inner city, and they have wireless devices transmitting, to their physicians or whoever. So if you could speak to that, anybody?
I'm not familiar in specific detail about wireless device transmission. I know we have a telehealth program at our organization, and I know we were collecting data from people's blood sugar machines, but that wasn't a wireless thing. So,
Any other questions? Last call. Last call. We have somebody? No? All right. Well, I want to thank our folks that asked questions, and I want to thank our panelists very much for participating and very interesting presentations. Thank you very much.